Hello, and welcome to this special webinar brought to you by Encoda. My name is Kevin Scorsone, and I am the Associate Manager of Patient-Centered Initiatives. We have a great webinar in store tonight, and I am very excited to get started. Before we begin, I want to thank our corporate partner, Exelixis, for their gracious support of tonight's presentation. I also want to mention that questions are welcome during today's presentation, and all questions should be entered into the Q&A box on your screen, and our presenter will answer these in the order in which they are received at the end of her presentation. It is now my pleasure to welcome Latha Radhakrishnan from the University of Illinois Oncology Clinic. Latha will be presenting on clinical management of first-line advanced RCC patients on CABOMETYX plus OPDIVO. Latha, thank you so much for being here tonight. The floor is yours.
Thank you, Kevin, for that introduction. I'm very excited to be here tonight with you all. I think this is Encoda's first evening webinar, and so I'm very proud to be giving this presentation. So as Kevin mentioned, I will be speaking, I'll be giving the presentation on the clinical management of first-line advanced RCC patients on CABOMETYX plus OPDIVO, which is a new indication. Next slide. Just a disclaimer, I am speaking on behalf of Exelixis, who is sponsoring tonight's webinar. And so this information is about CABOMETYX, even though this is a combination indication, and I won't be speaking on any one particular patient in this presentation. Next slide. So just to briefly review, CABOMETYX has a new indication in combination with nivolumab, which is indicated for the first-line treatment in patients with advanced RCC. And as review, we all know that CABOMETYX has an indication for single agent in the first-line setting as well as subsequent line settings. We will talk quite a bit about important safety information in the next few slides. Next slide, please. Okay, so we'll start off with a little review of an overview of advanced renal cell carcinoma. Next slide, please. So again, just a little bit of a review that we know that RCC is the most common type of kidney cancer, sixth most common cancer type in men in the United States, 10th most common in women. We know that there's roughly a little less than 75,000 new cases that were estimated in 2019. We know that the average age at diagnosis is around 64 years of age. Men are unfortunately more at risk in a 2-to-1 ratio compared to women. There are some risk factors here. We know that genetics plays a small role. So when you do have that younger patient, less than 40 years of age that comes with advanced renal cell carcinoma, you may think that there's a genetic component there. Smoking is a well-established risk factor. We know that about a pack a day can increase a person's risk to developing advanced renal cell carcinoma. Roughly 40 to 50% of renal cell carcinoma is due to obesity. So this is also another well-established risk factor. And other things that we think of are hypertension, environmental exposures that can also pose a risk. We know that about the vast majority of patients have this clear cell histology. And while, this cancer is diagnosed in early stages, surgery is an option and some other treatment modalities are an option. However, we do know that most patients are diagnosed in the metastatic setting. And in that case, the 5-year survival is a dismal 12%. And then again, we know that renal cell carcinoma is a highly vascular tumor, and this will be very important when we talk about the mechanism of action in the next few slides. Next slide, please. So we have quite a few options in advanced renal cell carcinoma treatment. And it's really interesting when I'm not going to date myself, but when I started, we really didn't have much in the treatment landscape. And what's exciting for us as practitioners, as well as for patients, is that, we're talking about CABOMETYX today, but we have so many options for our patients that go beyond just this one option. So that's really exciting, and we couldn't say that 10 to 15 years ago. So with regards to CABOMETYX, we know that the second line indication, it received second line indication in April of 2016, received a first line indication in December 2017 from the CABO-SUN trial. And then most recently in February of this year, we have the CABOMETYX plus OPDIVO approval in January of 2021. So very exciting, and we're going to be presenting the data on that tonight. Next slide, please. So as mentioned, the mechanism of action is really important here because this is a highly vascular tumor. So we know that VEGF, vascular endothelial growth factor, is a target. It's a well-established target in renal cell carcinoma. Also, other overexpressed, MET and AXL are also overexpressed in RCC, and CABOMETYX, it targets all three: VEGF receptors, MET and AXL receptors. We also know that MET, AXL, VEGF drive metastases through inducing motility and invasion of tumor cells. We also know that these three receptors drive tumor angiogenesis as well as modulate immune function in the tumor microenvironment. Next slide, please. So now we'll move on to discussing the latest trial with CABOMETYX plus OPDIVO, which is the CheckMate-9ER. Next slide, please. So the CheckMate-9ER is a phase 3 trial, and it was used looking at comparing CABOMETYX plus OPDIVO versus sunitinib. So here we have 651 patients that were randomized. These patients, again, this is in the first line setting, so no prior systemic therapy was inclusion criteria, and these patients were randomized in a 1-to-1 fashion to either receive CABOMETYX, and this is a new dose here, 40 milligrams daily, plus OPDIVO, 240 milligram flat dosing, IV every 2 weeks, or sunitinib, 50 milligrams daily for 4 weeks, followed by 2 weeks off. And this was continued until disease progression or unacceptable toxicity. The primary endpoint was progression-free survival, and key secondary endpoints were overall survival, objective response rate, as well as safety. I think it's important to mention a couple things. One was the median follow-up was 18.1 months. Also, they looked at all risk groups, IMDC risk groups, favorable, intermediate, and poor, and I'll talk about that in the next few slides. And then also they included patients regardless of their PD-L1 status, which I'll also talk about in the next few slides. Next slide, please. Okay, so baseline characteristics, the next couple slides talk a little bit about this. They were both balanced from CABOMETYX plus OPDIVO versus sunitinib. A couple things that I just wanted to point out here is that they included, as I mentioned, all three prognostic groups, favorable, intermediate, and poor, with the vast majority of patients in the intermediate risk factor group. And then also these patients had a pretty good performance status overall if you look at the Karnofsky performance status there. Next slide. A couple things I wanted to point out on this slide. Vast majority of patients did have nephrectomy or surgery prior to starting, but there was a considerable percentage of patients that did not. So roughly a little less than a third of the patients did not have prior nephrectomy. And again, as mentioned, PD-L1 status, they included patients regardless, but the vast majority of patients had less than 1% PD-L1 status. Next slide, please. Okay, so we do have some discussion questions incorporated into the discussion here or the program here tonight. So how does your practice prioritize efficacy outcomes when choosing a first-line treatment option for patients with advanced RCC? Do you look at overall survival? Do you prioritize PFS, objective response rate, rate of complete response, or treatment-free survival, or something else? And so if everyone can kind of choose what you all prioritize. And there's no one right or wrong answer here. It's just to kind of get an idea. Okay, so it looks like overall survival, progression-free survival, and objective response rates were the three that the practices prioritize in advanced RCC. Excellent. And those would be the, the endpoints that we would see here in this trial. Next slide, please. Okay, so just a little bit of a preview to the endpoints of the trial. So here we see CABOMETYX plus OPDIVO. We do see the results here. So for the primary endpoint of progression-free survival, you have 16.6 months with CABOMETYX plus OPDIVO. There is a double objective response rate as well as overall survival benefit, which I'll discuss in the next few slides. Next slide. So with our primary endpoint of progression-free survival, CABOMETYX plus OPDIVO is in the magenta color, and then sunitinib is in the gray. You do see that separation in the Kaplan-Meier curve. So here you have OPDIVO plus CABOMETYX, 16.6 months progression-free survival versus 8.3 with sunitinib. Next slide, please. When we look at the secondary endpoint of objective response rate, we do see a benefit here as well with 55.7% with CABOMETYX plus OPDIVO versus 27.1%. Important to note that you do have 8% complete response versus 4.6 complete response with sunitinib. Next slide. When we look at time to response and duration of response, there is a benefit here. So we'll start off on the left of the slide on the time to response. You do see a faster response here with CABOMETYX plus OPDIVO, 2.8 months versus 4.2 months with sunitinib. And then on the right of the slide, you have duration of response. So again, a benefit here with the combination, 20.2 months versus 11.5 months with sunitinib. Next slide, please. Overall survival was another secondary endpoint. So here, it's important to note that the median overall survival was not reached in either treatment arm, but we did see a 40% reduction in risk of death. So it's important to note that as well. Next slide, please. So again, as I mentioned when I was talking about the CheckMate-9ER and the dosing of CABOMETYX, this is new. So it is a new starting dose in the combination therapy of 40 milligrams, and then the OPDIVO dosing of 240 milligrams every 2 weeks is what we saw in the trial, but we now have a new indication for OPDIVO of 480 milligrams every 4 weeks. Next slide, please. So we have our second discussion question here. Based on your experience, which of the following adverse reactions are the most difficult to manage while treating a patient with CABOMETYX plus OPDIVO? Now, this is a relatively new indication, but just kind of give your thoughts. Is it diarrhea, hand-foot syndrome, fatigue, hypertension, or increased AST, ALT, or other? Okay, great. So looking at the responses, we have many of you choosing fatigue and diarrhea. And so you do have some overlapping toxicities here with your PD-1 inhibitors and your TKIs of fatigue and diarrhea, as well as increased AST and ALT. Next slide, please. Okay, so talking a little bit about the safety information from the CheckMate-9ER. We're looking at the tornado plot here, and adverse reactions occurring in 15% of patients or greater receiving combination CABOMETYX plus Opdivo. So you do have a little bit more diarrhea of 64% versus 47% sunitinib. I would have thought that there would be more fatigue with the combination versus sunitinib, but that's around the same at 51 versus 50%. They're both tyrosine kinase inhibitors, so you do see that palmar-plantar erythrodysesthesia. You may see a little bit more stomatitis with sunitinib because of the myelosuppressive effects, but then everything else is relatively similar because of CABOMETYX versus sunitinib. Next slide, please. Looking at laboratory values, this slide is looking at laboratory values worsening from baseline occurring in 20% of patients or greater receiving the combination. I think again, we do have higher percentages of increased ALT, AST because of the combination versus, sunitinib has a lower percentage there. We know that tyrosine kinase inhibitors, they increase, they do have electrolyte disturbances. And then we know that PD-1 inhibitors can cause that, can cause increases in sugars. But you do see that myelosuppression is a little bit higher with sunitinib, and that's something that we would expect, just knowing the mechanism of action there. Next slide, please. Okay, so I really enjoy this slide, the treatment discontinuation slide. This really just gives us a better idea of how patients tolerated the combination. So I'll start off with the right, looking at dose interruptions and dose reductions here. So you have 83% with the combination versus 72.5. So this is a higher percentage of dose interruptions / reductions. Obviously, we don't dose reduce Opdivo, but we can dose interrupt and as well as reduce CABOMETYX. So this is where you do have that higher percentage, 46% with CABOMETYX. And so then when you look at permanent discontinuations, you do have a much less percentage here of 20% versus 16.9 with sunitinib. This just tells me that we just really need to, be talking to our patients, which we all do, either by phone or just following up with patients and managing their side effects so that we don't have to permanently discontinue the treatment options here. It's important to note that the mean average daily dose of CABOMETYX in this trial was 30 milligrams per day. Next slide, please. Okay, so we'll move on to dosing and administration. Next slide. Again, this is just showing the combination CABOMETYX dosing and how to dose reduce this versus CABOMETYX as a single agent, which is review for all of us here. So the difference here is, again, the starting dose is 40 milligrams for CABOMETYX in combination with Opdivo. The first dose reduction would be to 20 milligrams versus, and then the second reduction, would be to 20 milligrams every other day. So this is new versus with single agent, we were doing 60, 40, 20. So now we're in combination, we're starting at a lower dose at 40, then we go to 20, and then 20 every other day. Next slide, please. Next discussion question is dosing. So how does your practice typically administer Opdivo? Is it 240 every 2 weeks, or do you all do 480 every 4? Or both dosing schedules are used equally, no preference? Again, no right or wrong answer here. We're just trying to get an idea. I think COVID may have changed some of this. Okay, so the majority of participants have chosen both dosing schedules are used equally, and there's no preference. And I would agree that UIC, it depends on the patient. So if we want to see the patient a little bit more frequently, then obviously we'll choose the every 2 weeks. But if it's a patient that we know is doing well, that's kind of on autopilot, then every 4 weeks would be totally acceptable as well. Next slide, please. Okay, so this is again just review of recommended administration of CABOMETYX. We know not to take CABOMETYX with food because a high-fat meal can increase the concentration AUC significantly at 41% and 57% respectively. So it's really important administration education of taking CABOMETYX at least 1 hour before or at least 2 hours after eating. Next slide. Again, just a review of dose adjustment guidance. Again, with CABOMETYX, I feel like all the tyrosine kinase inhibitors are different. I always have to look at the package insert. But with CABOMETYX, if the patient is complaining of a side effect, we will want to hold CABOMETYX. If we think that CABOMETYX is the reason why they're having this side effect, we'll hold. We'll wait until the side effect resolves to grade 1 or better, and then we will restart at that reduced dose. Again, with the combination, our first dose reduction will be 20 milligrams, and then a second reduction if needed would be 20 milligrams every other day. And so this is different than single agent, which would be 60, 40, 20. Next slide, please. Okay, just a little bit of a review again. So we know that CABOMETYX is a tyrosine kinase inhibitor that is metabolized through 3A4. So we do have to dose reduce if we are giving this with a strong 3A4 inhibitor. And we do have to increase the dose by 20 milligrams if we're giving CABOMETYX with a strong 3A4 inducer. So these are, I think, as pharmacists, these are things that we're doing every day. We're checking for drug-drug interactions. We're talking to patients about, not drinking grapefruit juice, grapefruit. We're checking to see if they're on any herbal products and doing those drug-drug interactions. So preaching to the choir here. So patients that do have hepatic impairment, their starting dose would be 40 milligrams if they're doing single agent, so 60 to 40. And then we know that because it's a VEGF inhibitor, we do have to make sure that we talk to patients about if they're having any elective surgery, that we do have to withhold CABOMETYX at least 3 weeks prior to elective surgery. And then we can't administer CABOMETYX for at least 2 weeks after any major surgery because of that impaired wound healing that can be seen. There is increased AST and ALT here with the combination product, which I'll talk about in the next slide. Next slide, please. So we'll go on to talk about the management of select adverse reactions. And so when we're talking about the next few slides, this is data that is coming from not only the CheckMate-9ER trial, but also the METEOR and the Celestial trial. So the METEOR trial was looking at second line or subsequent line therapy in advanced renal cell carcinoma, and the Celestial trial was looking at CABOMETYX and the HCC indication, the second line setting. Next slide, please. So from the CheckMate-9ER, I like this slide as well. Kind of gives me an idea of what the toxicities that were, what were the major toxicities seen. So you do have high percentages when you look at grade 1 through 4 incidents, with increased AST, ALT being high in the high 70% range, as well as diarrhea. But when you look at grade 3, 4, much less of a percentage there. Median time to first occurrence, this is really important for me because patients, I feel like they ask you, like, when am I going to get this diarrhea? When am I going to potentially experience this hypertension, this fatigue? And so A lot of this is not available, but we do have a little bit of data on the hand-foot syndrome, 7.4 weeks, and then the hypertension for around 4 weeks. So I think, that gives us an idea of when we need to follow up with patients, when, patients ask us questions of when should we be expecting something like this. We have a little bit more of an idea. Also, looking at dose interruptions based on and reductions based on specific toxicity here. We do have some data here for that. Dose interruptions, 24.4%. Dose interruptions or reductions were due to diarrhea, a little bit less of a percentage with hand-foot syndrome, and then 10.6% was due to hypertension. Discontinuations, very low. Again, this is really important that we're, again, managing these patients, talking to them over the phone, and I think as pharmacists, we do that every day. Next slide. Okay, so now I'm going to talk about specific adverse reaction management, and we'll start off with diarrhea. Again, the thought is, like, if we think that CABOMETYX is the reason for this diarrhea, we're going to stop the presses, hold, and wait until it gets better to at least grade 1. And then we'll start at a reduced dose. In combination, it would be 20 milligrams would be the first dose reduction. So here again, these are things that we do with, these tyrosine kinase inhibitors. We want to make sure that first off, that they're drinking lots of fluids. If they're telling us that they're having quite a bit of diarrhea, you're asking those questions. And if they're saying that they are having quite a bit of diarrhea, we're bringing them into clinic and replacing fluids, checking their electrolytes, replacing those as needed. And also we want to rule out other things. So, we know, from the METEOR trial that it was weeks for these patients to experience diarrhea due to CABOMETYX. And so thinking about that and thinking of that patient that, you've just counseled just the day before, and then 2 days later, they're saying that they have diarrhea, before we jump to, oh, it's the drug, we really need to ask them questions like, what did they have to eat last night? Did they have any spicy foods? Did they have any changes in diet? Talking to them about, what does their diarrhea look like? Is it explosive? Is there blood in the stool? Is it foul smelling? This all could be infectious. And so we need to work that up as well before we just start them on an antidiarrheal agent such as loperamide. Next slide, please. The next adverse reaction management that I'd like to talk about is hand-foot skin reaction. So again, it's the thought of, holding, waiting until it resolves, and then starting them on that lower dose. I think we all know how to manage this, at this point as pharmacists. So we're using those water-based moisturizing creams, analgesics if needed, talking to them about not taking those scalding hot showers, talking to them about wearing thick gloves in the wintertime, especially in Chicago, thick socks always, and proper shoes, making sure that, they're avoiding, again, that, protecting those pressure sensitive areas of the hands and the feet. Next slide, please. Our next adverse reaction is fatigue. Again, it's that same process of holding, waiting, and restarting. I think this is where I'm always challenged. Is it CABOMETYX? Could it be OPDIVO? Could it be, a wide range of etiologies? Like, are these patients depressed? Could it be hypothyroidism? Do we need to check a TSH again? Do they have baseline anemia? I mean, these are patients with advanced renal cell carcinoma. So are we getting an iron panel? Are they depressed? Have we, kind of talked to them about depression? They do have stage 4 disease. So all of these things really have to be ruled out before we just say, okay, it's the drug. And so really getting to that etiology is very important. We can consider pharmacological management with methylphenidate, not something that I really do at UIC, just because a lot of our patients are on so many medications that I just don't want to start them on something else. So we really want to narrow down that etiology and then treat appropriately. Next slide, please. Hypertension is the next toxicity that I want to talk about. I think with this, with high blood pressure, it's really important to identify those patients up front, really, and really looking at their comorbid disease states, identifying those patients that already have uncontrolled blood pressure. For me, the challenge is a lot of our patients are have their primary care or their GP in the suburbs, and they're coming to us in the city for their cancer treatment. So connecting with that primary care provider, letting them know that we're starting them on a medication that could increase their blood pressure, not tomorrow, not in the next week, but perhaps in 4 to 5 weeks. And so setting up that appointment with them has really, I really found that helpful on my end to just kind of set up that appointment and talk, one-to-one with the nurse or the physician in the outside of our institution. Next slide, please. Elevated liver enzymes, this is something that we did see with CABOMETYX as single agent. We do see this as a potential effect with the combination of CABOMETYX plus OPDIVO. So there are higher frequencies of hepatic effects with this combination. So we know with PD-1 inhibitors as well as with TKIs that we're getting that baseline liver function tests. We're checking these regularly and making sure that we're talking to patients and finding out, looking at their meds. We're pharmacists, so making sure that they're not on any other meds that could cause these transient increases in LFTs, and just kind of, making sure that that's not the cause. But we did see a higher frequency of increased LFTs with CABOMETYX plus OPDIVO. Next slide, please. All right, so now we're going into important safety information. Next slide. So we know that CABOMETYX targets the VEGF inhibitors, and so we know VEGF receptors, sorry. So we can see GI perforation, thrombotic events, hemorrhage, hypertension, hypertensive crisis. These are all things that we should have in the back of our mind. And we talked about diarrhea. So things that are in the back of our mind that we're talking to patients, not necessarily like really spending a lot of time with our patients about this, but really talking to them, making sure that they know to tell us if they're having surgeries and things like that, so we can withhold CABOMETYX while they're having this. Next slide, please. I've talked about palmar-plantar erythrodysesthesia and hepatotoxicity. One thing that they did see in the combination was this adrenal insufficiency. So that's also something that we should be, keeping in the back of our head. The percentage of patients that experienced this was 4.7%. So a lower percentage, but something that we should have in the back of our minds. Next slide. So we know that TKIs can cause proteinuria, and so this is something that we can see. Less than 1% of patients have this osteonecrosis of the jaw. We're still not sure what that mechanism of action is, but it could just be just impaired wound healing, and this could be the potential reason. And then we, of course, as pharmacists, we're talking to any of our patients, whether it's CABOMETYX or any oral agent. We're checking a pregnancy test if they're of childbearing potential, and we're talking to patients about using contraception, proper contraception, not only during treatment but up to 4 months after the last dose. Next slide, please. I've talked a lot about adverse reactions and drug interactions. Again, if you have a patient that is that potentially could be breastfeeding, talking to them that they have to not breastfeed during CABOMETYX treatment and for 4 months after the final dose. Next slide, please. And now we'll spend a little bit of time with the Exelixis support information. Next slide. Okay, so I think all of us are pretty familiar with the CABOMETYX patient care kit. So I have found the items in this kit to be very helpful, especially in my patient population at UIC. So just a reminder that it has a lot of good reading materials in here that are patient focused, as well as it has 12 caplets of loperamide, a 2-ounce utterly smooth cream, as well as Queasy drops. Next slide, please. So Exelixis has the EASE program or case manager. And so for your patients that do qualify, you do have the 15-day free trial program, as well as the quick start program for patients that it's just taking a little bit of time for the payer to make a decision on coverage. There is copay program, again, for this is for only commercially insured patients of $0 per month. What I'd like to focus on is the EASE dose exchange program. So just, I'm sure everyone's familiar with this, but if you do have a patient that needs a dose reduction from 40 to 20 milligrams, and insurance is giving you a little bit of a pushback because they just had the 40 milligrams filled, then the EASE program does provide a free 15-day sample for the lower dose. So that has been really helpful for our patients. EASE also has a collaboration with CoverMyMed. So you, in fact, can enroll your patients in EASE through CoverMyMed. So that's a collaboration that's relatively new. Next slide, please. Be connected with CABOMETYX. So this is an educational support program, not only for patients, but for caregivers. Letting patients know that there is this Be Connected program that is for patients and caregivers. It can, help patients recognize side effects, working with the healthcare team, but we do that. But this is something that, if you do have a patient that, that would benefit from this. Lifestyle tips offering wellness support, that could be useful. You can sign these, they can sign up on their own, or you could sign them up as a pharmacist, either online or by mail. Next slide, please. And we do have another discussion question here on support information. So which of the following is your preferred method or methods to help support discussions with your patients regarding treatment and AE management? So manufacturer website or online information, or videos, smartphone apps or interactive digital tools, printed material or brochures, wallet cards, or other. Okay, so wow, I was expecting a little bit more smartphone apps and videos, but I see that printed materials and wallet cards are being used, and that's actually what I use at UIC. I find that a lot of more patients they still have the flip phones, they don't have an iPhone or a Android, so smartphones really aren't something that I use with my patients. I do use the wallet cards for the PD-1 inhibitor, so that's great that everyone's using that. And I do use a lot of printed material still, so I guess I'm still kind of living 10 to 15 years ago, but it sounds like we're all in the same boat here. Next slide, please. Okay, so we're at the summary slide. So CABOMETYX plus OPDIVO, this is a new indication in the first-line setting for advanced RCC treatment. So here we did see a benefit in progression-free survival of 16.6 months with combination CABOMETYX plus OPDIVO versus 8.3 months with sunitinib. We saw a doubling of objective response rate compared to sunitinib, as well as a superior overall survival with a 40% reduction in risk of death. We did talk about toxicities, and there is, a high percentage of patients that will need a dose reduction, that will need a hold. And I think it's really important that we tell these patients up front that it's okay if they have to have a dose hold. It's okay if they are on a lower dose. In fact, the trial showed us, that's what we saw in the trial. So I think it's really important to talk to our patients and prepare them for that up front before we start this combination. And with that, I'll go to the next slide. And Thank you all very much. I'm really excited to present today, and I will entertain any questions at this time.
Latha, thank you so much for your presentation today. That was wonderful. I would now like to open it up for questions. If you have a question for Latha, please ask your question in the Q&A box, and we will get to your question in the order in which it is received. So we do have some questions coming in. Our first question, CABOMETYX can frequently be dose reduced due to side effects. So do you have any issues with getting the reduced dose to the patient in a timely manner, or do you use the lower dose table with a higher pill burden?
Yeah, that's a great question, Kevin. Um, I have not personally had any issues or delays in getting drug to the patient with the reduced dose. I think that the ease, if there is issues with insurance paying for that reduced dose, there is the ease dose exchange program offering that 15 tablet free drug, that one-time free drug to patients. So we've had to use that one time, but really we haven't had any issues. But I would definitely recommend, CABOMETYX, is available in 40 milligram tablets and 20 milligram tablets. So you do want to get them, that one tablet. That's ideal. So I think that's important that we try to get them that next dose to avoid that pill burden.
Latha, when you see a patient present with side effects, do you commonly ask about how they are taking the medication? It stands to reason that if they are taking it with a high-fat meal, that the side effects could be caused by the increased AUC. Is that correct, or are we misinterpreting that?
Yeah, absolutely. So you can see the concentrations AUC increase significantly, around 50% for both of them. So you do have to counsel them to take it, 1 hour before or 2 hours after a meal. It's a high fatty meal that you can see these increases, but I can't tell you what kind of meals. I probably eat a high fatty meal every meal. So I think it's better that we talk to them about, we definitely do need to ask, how are they taking CABOMETYX, even though we've counseled them prior, but talking to them, asking them how they're taking it. Oh, I take it, every day with my breakfast. That could, kind of lead us to, okay, we need to separate out your breakfast. You need to take this like an hour before or 2 hours after.
Yeah, thank you for circling back on that. Again, if you would like to ask Latha a question, now would be the time to type your question in the Q&A box. If not, we do have one final question of the evening, Latha. The slide deck indicates that the CABOMETYX should be dose reduced due to side effects. Are there any situations where the OPDIVO would be dose reduced or discontinued when given the combination regimen?
Yeah, a great question. So, from the CheckMate-9ER, 46% of patients, so 80, sorry, 80 over 80% of patients required a dose hold or a dose reduction. Of that, 46% of patients needed a dose reduction for CABOMETYX. 3% had a dose hold. So we don't dose reduce. We all know we don't dose reduce the PD-1, but we can hold it. But that was a smaller percentage of patients that needed the hold for the OPDIVO. And then there were a percentage of patients that needed to hold both. So you do have to, I think with combination, you do have to kind of tease out like which one is it, especially in toxicities such as diarrhea, fatigue, and increased AST, ALT or liver function tests. So it's really important that we're trying to figure out like which one is causing this and try to make our, and decide, what we need to do moving forward.
That's great. Thank you so much for taking the time to answer all those questions, Latha. And once again, Latha, thank you for being with us tonight.
Thank you so much, everyone. Thank you for having me.
Yeah, it's our pleasure. So once again, thank you to Latha for her presentation and to Exelixis for sponsoring today's webinar. We greatly appreciate your continued support of NCODA. From all of us at NCODA, thank you to everyone who was able to join us tonight, and we hope to see you all on the next webinar.